So these were our presentation, but as a group together, we need to discuss these facts and we need to discuss these questions actually. The first section could be core framing, and I would like all of you to participate quite openly. Should we define a difficult to control type 2 diabetes in the white paper, which we are currently talking about? And if yes, how should we be defining it?
Not coming down from below 9.
But a difficult to control. So that is an uncontrolled diabetes, right? More than 9% of an HbA1c is uncontrolled, but we can always add insulin. We could go for a basal bolus therapy.
So all the therapies possible.
Okay, okay. So should we be putting that? Smriti, can you record the conversations? Okay, okay. No, no, maybe just voice recording. Yeah, there's no universal definition anywhere.
There's no standard definition. We can come to some conclusion that okay, these are the patient which is which would be highly benefited with this screening. That is what we want in this paper.
Correct, yes. Yeah.
So that's
So
an
I think
expert
first is,
opinion.
yes, I think HbA1c 7.5% or greater. So first we can all agree upon, at least in our very uncontrolled patients, these are not the ones we are trying for 6.5, but if we all say, let's first agree on the HbA1c with maximally tolerated doses so that, this is the max they can tolerate of metformin or sulfonylurea or whichever other OHAs, SGLT2, DPP4. We cannot limit to 3 because 3 के पहले तो आते ही नहीं हमारे पास ना. Yeah.
But the data suggests that adding a fourth drug will not help. So I think we should stick to 3. It would look more scientific.
I don't think so. This is India level, so we are starting something new. So let's ask Dr. Rakesh. Yeah.
Say that somebody is on metformin and maybe imiglamine and maybe acarbose, he'll never get controlled. I mean, you cannot say that he's on 3 agents and he's not under control. So we should probably specify that which 3, at least something which is 3 potent agents, or we can say that at least one secretagogue should be there. Because we are dealing with type 2 diabetes, so we are speaking about type 2 diabetes, so we say that at least one secretagogue is there, so that
Dr. Rakesh, I just would like to comment.
I mean, that's open for everybody's comments. I'm just giving my thoughts.
So that is basically, a poor control or OAD failure. It's not difficult to control. Try to understand, we can add. So I think we have to frame it like that despite of rapidly increasing the doses of anti-diabetic agents, including everything, because you're free to use anything. We cannot say 2, 3, or 4, or if it is 3, it is 4. You add GLP-1, you add insulin. So despite of best of the treatment, rapidly increasing dosing, A1C is not coming down. Something like that. It is all arbitrary.
One more thing I want to add, because the HbA1c cutoff is very different for everyone. So it's like if you're staying more than 1.5% away from the target A1c for that particular individual.
It could be for.
No, but that means all OAD failures will point towards this? No. Yeah. So this is what we are trying to say, that patients who are not responding are basically a failure. That is not this. There has to be some kind of a speed of increasing medications and A1C not coming down. It is like when we talk of anti-obesity. When we talk of anti-obesity, we say after say 3 months of treatment or 6 weeks of treatment, if no response, it is taken as a.
Is there a standard definition of difficult to control diabetes?
No, but what I can say, there is a beautiful paper which entails 10 patients who are all treated with almost every injectable agents, including insulin, either tirzepatide or semaglutide, in addition to oral agents and multiple antihypertensive drugs. Or there's a recent publications with 10 cases. So these type of cases we should be talking about. There is no consensus how many drugs would be there, but this is I'm just telling, giving you a perspective.
Ashish, you can note down.
Uh, and we were starting off with 3 drugs and 1.5 units. I mean, there's a huge variation. So, do we have a standard baseline definition in existence already? I don't think so.
No, no, we don't
So,
have
where,
any
so,
standard definition.
so where do we start? I mean,
Uh, my idea was that
yeah,
because guideline don't recommend to add a fourth OHA, that's an standard
yeah.
definition that beyond third OHA, the fourth one is not going to act. So I think
There is
that
no
is what you
guideline.
can put as a difficult to treat something like that.
No, 1 second. Which guideline is saying?
ADA also
No,
recommends.
no, they are just saying.
Yes, but we have to take some of the baseline that
No, but
from where we are taking the data.
so sorry, I beg to differ. ADA has not said that don't give more than 3. They're saying after 3, go to insulin.
Yes,
They're not saying you don't add
yes.
4 and 5. They have never mentioned that.
So I think the point of discussion here is not about whether 3 drugs, which drugs, and how much and how much is the HbA1c. We are not trying to debate that. Our debate is today on where should we suspect hypercortisol. So what I feel is that let's not break our heads on what is difficult to treat. Let's say that we just leave it at that, difficult to treat, whatever, however, because the most important thing is a difficult to treat person who is lean and thin is not the one who is having hypercortisolism. So we should accompany, I mean, we should add on to that obesity, difficult to manage hypertension. So those things, when they're together, then that's the setting for a hypercortisolism. It's not a lean and thin fellow whose BP is normal, whose BP is on the lower side, and he has got a blood sugar which is 400s, not controlled with insulin and all the other agents that you're giving. He's not the one who's where we are suspecting hypercortisolism. So let's not break our heads on difficult to treat, but say that difficult to treat along with the in the setting of a high blood pressure and requiring more than 2 antihypertensives and having obesity and such things. Yeah.
So I
So if we
think
can give a sort of global this thing, that will
one
make it
thing
better.
that we can take into purview is that even if the person is lean, if there's an obvious change in the body composition, if we see that the belly is growing, I think that is one of the, you have to have a high index of suspicion when there is a changing body composition, where there's increasing abdominal opacity.
So, what would be the clinical points that we should be considering when we are looking at a possibility of hypercortisolism?
Yes, see, our idea was from the catalyst trial. So I'll just tell you what are the inclusion point. So that will give you a better idea. What they have included is difficult to control type 2 diabetes, defined as in that trial they have defined HbA1c more than 7.5, taking at least one of those points, taking at least 3 or more drugs, taking insulin plus other OHAs, taking 2 OHAs plus one of the complication either macro or microvascular, and 2 or more drugs with 2 or more antihypertensive. That is what they have taken in trial. So we can exactly copy paste or we can come to some our own idea. Again, it would not be a database. It's a consensus expert opinion. We need not go with all those data backup now because we don't have data.
Today we don't have such a trial from India, so we don't have a good evidence to back on. But we can just say that somebody who's diabetic, difficult to manage diabetes, and 7.5 in our setting would include most of our patients. So it's better to say more than 9% or 9.5% with who is obese and who is requiring more than 3 antihypertensives. I think that becomes a reasonably good this thing, so
So I
that
think all agree with the 9 cutoff. Should we go with 9?
No, they would
no,
be
I mean,
people who are having hypercortisolism. See, I think what we can say is poor diabetes control in presence of obesity and resistant hypertension, something like this.
Because if you're going to take
Because we have
7.5,
to take
I would say
everything
about 50%
into
of my
account.
patients will come under that. So I don't screen all my 50% of my patients for hypercortisolism. Otherwise, I'll spend all my time doing that only, rather than controlling their diabetes, giving them dexamethasone and seeing their glucose value. I mean cortisol values.
So we can add, in presence of hypertension and obesity.
So it's not just 7.5%. The reason we are also discussing this is that it'll be 7.5%. Here, what I think the discerning factors with the Indian scenario is that we agree with the point that the guidelines and ADA has 3 OHAs. We don't do that in Indian practice. When I was
Agreed.
in US, yes, I never used sulfonylurea. We didn't have anything beyond glipizide 5 milligrams, easily available. So that is very different scenario than what the Indian scenario. So if you're maybe we extend to say 8% because we are a bigger country, we don't want to screen millions. But 9%, I agree with Dhruvi, is absolutely to me uncontrolled. And you would still be, making. I think 8% we can agree upon in the Indian scenario that we start off at least for this and we can revise it next year depending on what we see. And 8%. And then I also agree with Dr. Rakesh that we need to say which OHAs in our scenario. If they are already on maximally tolerated dose of metformin, sulfonylurea, some of the stronger OHAs, not metformin, just DPP4 and alpha glucosidase
So
inhibitors.
we can include
We
three or
can
more
say, yeah,
OHs,
3 or 4,
including one
including,
secretagogue.
yeah. So I think if we say that and then or also saying the 2 or 3 OHAs plus basal insulin, basal bolus therapy with an insulin sensitizer. So we can have several criteria and blood pressure if you want to say 2 or 3 medications and blood pressure is still high. So we can have those subsets, I feel, under that. We can have a little bit longer list.
So resistance hypertension definition is already standard, three or more antihypertensive, including one diuretic. That's the classic standard definition. But we don't have anything for diabetes.
Also we
I don't
can
want to agree with the
also we can
8%.
probably, sorry,
Yeah,
also we can have probably a BMI cutoff also, because a lot of these people are obese. So should we think of that also in the, because while we are setting it?
I think we can just put obesity, that would be good enough.
Yeah, but some BMI cutoff, it's because see, 23 is now the Indian or the South Asian, whatever. 25 or a waist or yeah, something like that should be there.
That waist, yes, waist circumference is better in that scenario because hypercortisolism specifically increases the intra-abdominal fat. And that is the one point. If a patient is receiving in the same lieu, patient is receiving GLP-1 receptor analog and is not losing body weight as he was telling, that could be also a clue for hypercortisolism.
That's why we have the criteria that if you're receiving SGLT2 inhibitors, if you're receiving GLP-1 analogs, and you expect that to come down, in spite of that you're having uncontrolled diabetes, then you suspect hypercortisolism. But my point is, let's not go with a cutoff of 8% or 9%. But as I said, 1 year you have tried optimization with whatever agents that you want, yet your A1C is more than 1.5% away from the target A1C for that particular individual. Because we have every individual will have a different cutoff value, individual
Agreed.
target HbA1c. So if you are away by 1.5%, because Kamlesh Kunti's group clearly states that within 1 year, if you don't get the A1C to the target level, you significantly increase the chance of a cardiovascular event. So 1 year is the
So
time to up titrate.
yeah, so this 1.5 or 1, have you taken from some data or it's just
1.5 is the standard definition.
okay? So 1.5, I think we can all agree on that. Let us say somebody having 6.5, it would be 8. For elderly, it would be 9 then, something like that. 1.5 above the cutoff. Above the target for that individual. That is what he.
Define each time for the individual. It becomes, I think now you're leaving it to the discretion of the primary care physician or whoever's going to screen. And you need to decide first the cutoff and then you will, so I think that is a little bit more confused in the context of guideline setting when you do it.
It can be like
Let's not go that deep because it will unnecessarily complicate the whole paper and we are just on the first point. We can just
Why don't we take a vote for 9, 8 and 1.5 and
yeah, that we can do.
I think we can do like 8 and maybe 1 or 1 and or.
They have mentioned it that I have told. I'll just go to that so it would be easy for everybody.
that's the idea.
Just that way. It's not a question of that. A lot of times.
Theoretically, it's just theories and that's the reason also on these slides. 7.5 to 11.5. It's a range.
And at least see, that's what now. At least taking more than 3, taking initially. This is better. This is actually yeah. Yeah, why not?
So it's more than 7.5. Simple. It appears more than 7.
Yeah, because it should not be that if it's not less than 8, you cannot screen. But if it's 7.5, but they have written all
Pointers. They're all pointers.
Should we very strongly talk about the impact of treating hypercortisolism on the metabolic outcomes? Yes or no? Should we talk about it as one of our sections?
Yes.
And its interaction with the CGM insights? Do you think that treating the hypercortisolism and the CGM readings would be, the glycemic variability would be impacted?
But we don't have data yet, right? So how are we going to show that?
No idea. Maybe we just try to be
So just one question. Now, we said difficult to treat diabetes, so we are suspecting hypocortisolism. So then what do we check?
The previous slide.
Yeah, that was the previous slide, which,
Ah, we missed
which is
the
not
slide.
there.
Yeah, where
Which is not there.
where did it?
What are you going to check? How are you going to?
Yeah, so that was our next question, whether you want to stick with ONDST or whether you want to go with other test. Also, the trials don't mention, but wherever you read the Cushing's, it is the first circadian rhythm is disturbed. So do you want to go with midnight cortisol, just not the salivary, midnight serum cortisol and morning serum cortisol to look for the circadian rhythm so as to pick more patients? So this was an expert question which we wanted to ask.
Definition.
Terminology of hypercortisolism spectrum. Again, will you make to answer or should we go with the what existing guidelines?
So how to define hypocortisolism in type 2 diabetes? That's our main question now.
Then the approach would be different. And if you think it from the diabetes point of view, then a little bit different approach should be there.
You can.
Like I'm explaining a little bit. In case of diabetes, if you are suspecting hypercortisolism, the first test should be ONDST, overnight dexamethasone suppression test, 1 milligram. If the cortisol level is more than 1.8 microgram per deciliter, the diagnosis here is established. Hypercortisolemia is there. What is the next step? The next step, they usually did the abdominal CT scan to look at into the adrenal gland, and then they did ACTH test. If ACTH is less than 5 on the lower side, that means the cortisol is coming from the adrenal gland, which is also known as max. So, and the cortisol excess in type 2 diabetes mellitus is mainly from adrenal gland in 80% of cases. And if ACTH is more than 5, they did an MRI to look out any pituitary disease or not. That is how they approached in that particular study. But if you look from Cushing's disease point of view, I would have liked to do a LDDST test or HDDST test. Then possibly I'll my cutoff of ACTH will be different. More than 15, it is Cushing's disease. Less than 5, then I will go for adrenal disease, like that. So, but to keep it simple, it is better to do an ONDST test followed by a ACTH test. It is if it is less than 5 or near normal, lower on the lower side, and they have also sent a blood sample for DHEAS. In DH in adrenal Cushing syndrome, DHEAS and the ACTH levels are on the lower side. So if those pointers are there, they directly did a abdominal CT to look at the adrenal gland.
See, but the thing
Please,
is,
please.
even in AI, if you look, the DHEAS levels will be low. So that is a surrogate marker to look for instead of doing, low what do you call it, short synaptin test. If you do a DHEAS, you get a good sort of a idea whether the person is adrenal deficient or not.
My question to the expert was whether you want to put a night cortisol because it's a very high negative predictive value. So can we use it Indian context and we can give this idea that okay, we'll be using this so as to save the cost and because this is high negative predictive value.
So, Mayur, what will you put as the cutoff to rule out Cushing's in the Indian scenario for the night cortisol level? Just to
Usually
clarify.
it is somewhere around 7.5, 10, then
Yeah.
wake, whether sleeping. So depending on that,
That is
there
what
are
I'm saying.
cutoff from
Yeah.
150 to 200 or say 7.5 to 14 microgram per DL. So that's an expert opinion we can discuss and we can
Yeah.
come with something newer thing because otherwise it would be just a replica of what is already done.
So we don't have to come up with new things. We have Indian data which we can look at, and therein they have found the 1 milligram dex suppression test was better suited for the Indian scenario because of our circadian rhythm not being as set as a lot of the people and having reliability of the values and everything. So the 1 milligram dex is better suited for the Indian scenario. My God, sorry. For the Indian scenario has been established by groups in PGI Chandigarh and all of those. So I think we can look at that data and draw from that. Um, because again doing ACTH, as you also know, even in any good rich setting also it's an expensive test. The ACTH has to be collected in a purple top tube, has to be flash frozen, all of those steps, then you
It's
have to
a
rely on
thermolabile.
whether it is done in the right way, transported. So I think the ACTH will be have to be done in a tertiary or a secondary center, even if we find people in different parts of the country having positivity. So that should be also written that the test is collected appropriately for ACTH is very, very important. So I think, in my opinion, the 1 milligram is reliable, but even then we will always need a cortisol the day before, right? You'll need two cortisol values to see the percent cutoff, or do we go just by that 1.8 microgram per deciliter? It's below that. So that is something we
And
But
will
one
Dr.
test
Richa,
is good enough.
do you think 1 mg suppression test is, good as a screening test in Indian circumstances?
So that
We
is
have we
the
are trying to
question again is
identify
that are we going to do two tests? That's what he's asking, or
Yes.
one test.
we are trying to identify a test which is going to be, easily accessible, what we can do as a screening test, and then take that up as a confirmation. That's fine. So 1 mg suppression test is fine as a confirmation, but as a screening tool, can we use the midnight, cortisol level is what the question is about. So let's have a raise of hand on that, and then we'll close that, and then we'll move on to the next one because things are getting confusing now.
Yeah, and also for the exclusion, we will require an 8 a.m. cortisol. So these are 3, 4 questions which we need to put in consensus. To exclude exogenous Cushing, you require a morning cortisol. So should we put in consensus that every doctor should get this test first? No?
I think, no, yes, sir.
Or rather Cushing's is a big area for endocrinologists have been spending their lives trying to understand,
Yes.
trying to have a series of patients where they're looking at, and even
Any
the
class.
people who have been working on this area are actually at the end of the day will still find it difficult in every patient. So what I feel is that we are looking at putting this across for for a large population of diabetic
Yes.
patients where we are trying to see whether this is a relevant, I mean, is a important issue which could be, affecting their glycemic control. So I think we should make it simple. We should say that, uh, suppose somebody does we are not looking at Cushing's. I mean, we are not trying to screen for Cushing's. We are trying to identify if hypercortisolism is playing a role. So we do a overnight dexamethasone because we don't. Otherwise, ideally, you should do a early morning cortisol to exclude somebody who may be having
Steroid.
having steroids. So this guy would be overweight, will have difficult to control diabetes, will have all these other things, but his cortisol will be low because he's taking exogenous steroids. So here we are just doing dexamethasone suppression test because we are trying to look for endogenous hypercortisolism.
So we can put just a point that a history should be taken in detail.
Yes.
Something like that we
Yeah,
can
yeah.
put
So
in
we
consensus.
put the caveat that we need to exclude any form of exogenous steroid use, although it's we would like to do the test, but we don't want to complicate it. And second thing is, I think the when serum cortisol only, ONDST and a midnight cortisol. I think these are two tests which are well validated. Yeah, overnight, 1 milligram.
The overall idea is like that, to make it simple. To make it simple.
There is a problem, you refer.
Yeah,
Just
there
one
could
question.
be some patients whom now the other issue is that there are these people who have a autonomous secretion, cortisol secretion, which is not significantly high, and they are in that zone. So those are the people probably who are the ones who will come with difficult to control diabetes. They may not have other very florid features of Cushing's. Otherwise, they would not be in the category of diabetes. We are more worried about their Cushing's, and we are trying to evaluate them and treat them for that. So this is a patient with diabetes who is not well controlled.
We call it MAX.
MAC.
So just
Adrenal cortisol secretion.
So
what we are trying to
before
say
we
here,
move forward, I would ask practical question to everybody. How many of you actually get an ONDST in your uncontrolled diabetic patient? Just raise your hand. And how many in a month you do get?
Since the catalyst trial, I'm doing more and more.
So how many in a month?
How many
Approx.
positive have you got?
In a month.
Yeah.
How
So
many?
how many?
Not more than one per month.
Not more than one per month.
And how many have you?
How
found
many turned
positive?
out to be positive?
So, and I've found at least 3 to 4 positives in a year. So
In a
around-
year.
In a year.
Because what the data is shown here is like 23%. That is not what we are seeing here.
yeah, I just had one question because you're discussing, no? So now, as he said, it's actually the adrenal cortisol levels which is trying to contribute to hypercortisolism in type 2. So is there something where we can bypass all this ONDST and just like he said, DHEA or some other blood marker which would identify an adrenal cause rather than looking at pituitary, ruling it out, then going for adrenal?
So basically, what they look at is first, do you have a cortisol excess? And then you find the source of the cortisol excess, whether it is the pituitary or the adrenal. So a simple test could be a diurnal loss of diurnal variation. If you want to make it very simple, there is a morning evening test. Some people may like to do that. Overnight dexamethasone suppression test is better in that way because it's very clumsy to do the morning evening. So that way it is there. I only a few patients I've found, I don't know people's experience, patients who got obstructive sleep apnea, there the overnight dexamethasone suppression test is a little, a lot of these patients, sleep problems, it gets a little difficult, but as a rule, I use that a lot as a screening test.
You have to establish hypercortisolism anyhow. Then you look for the etiology.
So that is what I was saying. Can we use a midnight serum cortisol 11 p.m.? It would be very easy in the Indian context, cost effective, and then we can do a pilot project with 10 controlled, 10 uncontrolled patient, and we can see what we are getting. Say 10 people do 10 patients, something like that. We can come up with a cutoff that is different from this consensus paper.
Correct. Dr. Mayur, you can tell us the 4 modalities we used to use in diagnosis of Cushing's disease. For
Yes, so
screening
usually
purpose.
it is ONDST, 24-hour urinary cortisol, salivary cortisol, these three, and then LDDST and maybe HDDST. That's what we do in general. Out of this, I think it is very clear everybody would like to have ONDST. There is no doubt over this, I think so. Anybody want to differ?
High degree of clinical suspicion to do a test, because otherwise what will happen, will get a lot of the problem. Second is of the test, I think overnight dexamethasone suppression test is convenient, easy to go for. If you talk of the saliva and all, I think there's a lot of problem because I don't know if you are considering midnight saliva test. I think that is not a good choice in the sense, first is its specificity and sensitivity comes only when there is a florid signs and symptoms of hypercortisolemia. Mild one won't catch. Second is that technique of collecting the swab is very difficult. Therefore, my thought is same as have been discussed. Overnight, straightforward, simple to understand. If there is a clinical suspicion and you are driven to test, then it would be overnight dexamethasone. That's my thought here.
As Mithun was saying that he is doing around 10 in his suspected person with diabetes, probably who are uncontrolled, and he is picking up only 2 to 3
in a year.
in a year. It means out of 120 or 100, if we are not saying 100, 2 to 3 uncontrolled diabetes, while the international data is showing that your uncontrolled diabetes, which as per definition, who are on 3 plus minus on insulin therapy, who are not able to even achieve right control or not able to get control with suspected condition, you may have around 30% to 40%. So the number is very high. So is it either we are not doing for right type of patient, we are not screening them, or we have less incidence? What is exactly, so should we say any comment on it? Because our interest is not here to just discuss about that adrenal or cortisol, whatever the test which we are finding. First, number one problem is, do we have this issue? Because whether tomorrow some therapy is to come or not, that's again different. Because we know 2/3 of our diabetic patients are not controlled. So one, we are always saying it is clinical inertia. We are not up titrating the therapy. Patients are non-compliant and they should be given GLP-1 and they are not taking. We should be given insulin, basal bolus therapy. So is it other than that? This is very important area where 1/3 people, even whatever you are best you are doing, is still not getting control. So is it the problem? If it is the problem, then how it is to be diagnosed? So first we have to tell across the country, why Diabetes India, with this consensus, with this paper, that when you should suspect. And if you are suspecting, this may be your easiest screening test. After a screening test, a physician may not be comfortable to do further testing for that patient. It's okay. They can refer to the appropriate center where they can be investigated more intensively to diagnose and for further treatment. This is what I think from a Diabetes India perspective, this should be our goal of doing this paper.
The answer to the first part, in my clinical practice, I would say in a year I do some 40-50 tests. Not more than 10% comes out to be positive, and we do test not just for not control. We do only in high clinical suspicious of Cushing's. Still, it is 10%. It is very low.
So I wanted to show you that video we had put in the group also. You can have the lab differential. Then on slides, he is talking everything about that. Not even the catalyst lab. The two video which are already available about the incidence, prevalence, and then he talked about the catalyst trial also. Both we can run and we can show. Even his slides are also there. So if that is what they are suspecting, 30-40%, it means either we are not suspecting right kind of patients, or if you are saying that even you are suspecting we have high index of Cushing, even though you are not getting, it means the incidence itself is low.
Yeah. So I think if you look at, I mean, of all the discussion till now, I think in most members of the house have not been seeing this. Even those who have been testing regularly have not been identifying, identifying Cushing's. Yeah, and even Rucha said she is doing quite a few tests and not picking up many of them. It's not in the range of 25% of the tests being positive. So I think what we should be, I mean, what our consensus should be, that we need more data on this sort of people who have been tested in that study, and we do a overnight dexamethasone test all across the country. I mean, all the people who are here should do it in their practice and maybe get data on say 100 patients in the next 1 year or so, and or maybe next 6 months we do we screen at least about 100 patients,
So
and
if
then
we are doing
compile that and say that okay, whether we are really seeing a significant problem, or this is not a significant problem in our part of the world.
so just to
So that's
add,
what I would like to say. Yeah.
so Dr. Rama Walia and colleagues from PGI Chandigarh and Dr. Anil Bansali have extensive data on Cushing syndrome, and we are in touch with them for PCOS and these diabetic. They have already shown in the Indian scenario, what Mayur already pointed out, that the 1 milligram dexamethasone suppression highest sensitivity and specificity. They compared all the tests. They did 1 milligram DST, late night plasma cortisol with ACTH. They did LDDST. They've done all. So those two tests have in the Indian population shown the highest. So if we are doing in a control setup also for diabetes, we should do 2 or 3 different tests, all of us. So that is what.
Whichever test is it been already done by some group or in PGI Chandigarh, we all may agree for that. First, whoever who are doing, they are saying they are seeing only 10% or 5% or 3%. So is it our incidence is already less? Or the second is they are already in suspected cases. They are trained and organic only. They are not the primary care physician. If they are saying, it means if we go to primary care physician and we ask them, all your uncontrolled type 2 diabetes patient who is already on triple drug plus insulin therapy, not getting control, you suspect this. Is it worthwhile or not to tell them? That's my point.
Dr. Yeah. Dr. Bansi, I just want to say that here, most of the people are who are having, in trade means they're in the clinical practice, not from the institutions where, heavy load of or true endocrinology, institutions. So I think if we take data from AIMS, PGI, I mean, like, then
Yes, yes, different.
Also doing, and when they get the reference from some physician के sir और उसको देख के लगता है कि इसको
Ah,
cortisol excess होगा, then he is suspecting them.
it is not for uncontrolled sugars.
Yes, Michael Hermans from Belgium. I was wondering if you want to have a high yield population, you should probably base your screening on the patient characteristic at baseline in that study rather than the entry criteria. Could be a little different. You see what I mean? Let's say that the baseline characteristics, you have the average HbA1c, could be much higher than 7.5. So I would look more to the baseline characteristic of the catalyst trial rather than the entry criteria. That's probably why they have such a high yield. Even if you have very broad entry criteria, they could have already selected a population whose baseline characteristic will yield a very high return rather than the entry criteria, which is quite broad as far as I'm concerned. Actually, I'm a diabetologist, so I never do endocrinology. I just refer to my colleagues. They are eager to pluck up. So I never do the test myself.
So I think the point is very important that what Michael has made is that, instead of looking at just the 7.5 to 11 was the entry criteria, but amongst these patients where they found 25% prevalence, let us look at what was the baseline, what was the average HbA1c in this group? Was it 7.5? Was it 8.5? Was it 9.5? So we can look at a similar cutoff so that we can get a higher yield. So that is what we are saying. We are not trying to get every patient of Cushing's included in this. We are trying to see that in whatever we screen, we should have a higher yield. That is our objective of defining whatever cutoff we want to use. So I think we don't have to really follow exactly what is there, what is the cutoff in that study, but look at the mean value, and particularly the mean value in those who were turned out to be positive, those 25% who turned out to be positive, what was the mean value? Maybe that cutoff we can use, and we can then expect a higher yield. Ultimately, we want a higher yield, try to identify those where we screen, we should have some positivity in that. 14%, not always. See, cortisol is not the only reason for somebody to develop diabetes. I mean, if that we are not looking at hypercortisolism, cortisolemia as the cause of diabetes. Diabetes has got 101 causes. We know that, and the major cause is insulin deficiency itself. So why do you worry about cortisol? I mean, so cortisol is in a subgroup of diabetics who are obese, who are having difficult to control blood pressure, who have got a phenotype where we should suspect. So we are trying to identify those patients where we should screen for cortisol excess and get a good yield of that.
See, but in the Indian context of HbA1c, iron deficiency is very common. Okay, where I live, hemoglobin E disease is very common. Hemoglobin E trait, thalassemia is very common. So I don't predominantly HbA1c. I don't use that much only. I go by the sugar readings because it's I don't know what's happening. So their criteria in Indian subcontext with iron deficiency, which is common pan India, our criteria may differ or not.
So why don't you do a surrogate like the fructosamine?
So fructosamine test, what am I going to achieve? If I have the sugar readings, then I do a CGM. I'm getting a lot more information with the cost. So that's
Yeah, we are running late. The whole idea of this meeting was to come to some conclusion.
Would be teaching them sleep hygiene, asking them to reduce the stress levels, bringing down the body weight or addressing the abdominal fat loss at an extent with the kind of agents that we talked about like the GLP-1 before taking them up for the test.
See, now if you talk in that detail, it would be really tough. Also, in fact, pioglitazone will change. Dexamethasone absorption itself is difficult. They have measured dexamethasone. In fact, nobody of us have measured dexamethasone in their lifetime. So this cannot be done as they have done.
Addressing the other factors that can increase stress levels before we take them up for the test, or we just test without.
The whole idea is to give some consensus, which is an easy understanding that okay, I'll screen this. If we put too much of complication, I think this paper would be then useless.
I think what Mayur, what you can have is criterias when you should suspect. And if you suspect, you do an ODST. And if it's positive, you refer. If you're still high suspicion, then also you can refer if you feel that ODST is not enough. That
So
should
because
stop
we don't want to go in this treatment detail, all those, because then it is more of Cushing's rather than we sensitizing people for hypercortisolism. Do you understand the difference? So that's not the aim of the paper. And the second part, when I was reading this, because whatever you do, we are not generating here any data. So we can come with this close group can come up with this, that maybe I'll see 10 patient controlled diabetes and 10% uncontrolled diabetes. Some of tests we would be doing and we would be coming with our own data, because obviously we cannot do like their treatment part and then follow up. This is impossible for us to do. So we can do comparator study. That's it.
If you want to get the estimate of hypercortisolism in less dose, beyond the HbA1c, you should have a consensus statement that whom the test should be done. Whom would you do the test? There should be a very clear. Otherwise, what will happen in one center, we can pick up 100 patients, and most of them didn't have a high index of suspicion. So you should have a consensus statement that who would you like to investigate. I think that would give a more uniform data. Thank you.
Yeah, so I think, all of us are saying the same thing in different ways, is that, today we don't have enough data from our country about hypercortisolism, but there are interesting studies from across the globe which have, the interesting studies means there only one study. We are basing it on catalyst study. So there's at least a study which has shown a very high prevalence of hypercortisolism in people who are uncontrolled diabetics. So there is need to study that in our population. So that is one thing we are all agreeing upon. I think everybody is agreeing on that we need to get more data on this, and we all agree that we are going to define the criteria for those patients whom we are going to screen, and all of us are going to screen at least about 100 patients, and at the end of a period which we decide, maybe 6 months, we have 20 people across the room, so we'll have at least data on 2,000 patients. Everybody does about say 100, or 100 maybe too much, so maybe 50. So we'll have data on 1,000 patients from across the country, and that would be good data to say that yes, is this a important factor or not. If it is not, let's not worry much about it. If it is, then we'll next year discuss about how we should go about with the treatment and all that. That's my take on this.
Hi. So that is the discussion that even those whom we are suspecting frank Cushing's in our clinical practice, how much positivity you see. These are like very subtle cases. In frank cases also, how many in your clinical practice you found it. So it is very less. So should we bother about it? That is what is the message we want to give. And how a physician or a person practicing at district level should evaluate. That's the whole concept. So we have to come with our own data to tell this actually. Yes.
From the experience also, when we ask everybody how many patients, such patients have we found in the last 1 year or 2 years, I don't think anybody has found any significant number. So I think we'll have to say that our experience on this has been that we have not seen significant number of patients having hypercortisolism. So there is need to study this in the light of the catalyst study. That's the consensus that
Study they have done, but the Ralph DeFranco and Ralph is, very aggressive, and he says that everyone get convinced so much so because I'm listening him for this particular problem since last almost 10 years, 8 to 10 years. He started first in ACE and then in ADA, and then now it had become very big. And every time last year in ADA there was separate symposia on it, and catalyst trial was he published. So what he had, whatever the data which he had shown, when you listen him, you find that yes, your every second patient you are going to get it, or every third patient. But in India, I mean, why we are not suspecting? Is it really less? Or even there are a lot of Americans are also not, they agree on the same. I requested few of US guy who are here. I requested them to be part of it, and then they told no, 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 we don't want. So Dr. Anand Basu is here, Rita Basu is here today. I asked them to come and join. Even this guy, he had gone for in-hospital hyperglycemia. Sagar also. So they have not
So
agreed.
my idea was when I was reading all those things, my idea was we can have some 10, 20 patient everybody who would screen. We give a basic guideline that okay, we will screen these type of patient, obesity, let us say three drugs, three antihypertensive, all those, and then we match it with how many factors were there and what was the cutoff seen, and then we can come to a conclusion. See, this 1.8 cutoff is for Cushing's, and again when you talk about this is about specificity. The lower you go, the sensitivity increases, the specificity decreases. So we can come to some cutoff that these type of patient are the one who would have hypercortisolism, something like that. We can drive
So
our
what
own
will be
data.
the name of paper? Let us come to the conclusion because we have to end this somewhere.
Indicot.
No, 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 no. I mean, whatever it is, you wanted to know by this paper, we will circulate to these 20, 30 people, maybe another 20, 30 who are interested. From 50 people, we will be asking that, send their data, at least to screen. At this point of time, only basic screening to whom you are doing. And the
Which
first
screening?
paper can be done only with that. May not be doing more about it, may not be doing more therapy.
Only
We may think of
ONDSC,
it, maybe
that's
a
it.
continuous process because this is something which is really new. It is not like in hospital hyperglycemia consensus or diabetes in elderly. This is something very interesting, and I'm sure everybody will be interested.
contribution of hypercortisolemia in diabetics, uncontrolled diabetics.
As a metabolic disease modifier in an uncontrolled diabetes.
Yeah.
In uncontrolled
That is what we want to see in our population, in an Indian population.
And will you consider this is a very strong modifiable risk factor which you can do modify?
And then we just measure the ODST.
That's it.
No other, no
Nothing, no after. कुछ नहीं, बस इतना इतने में स्टडी एंड.
बस
One point, suppose we come to know there's a patient got hypercortisolism and diabetic patient. Our management would remain the same.
No, 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 no. Management will change.
Just a moment. So it would be lifestyle modification and escalation of.
Ethical clearance when you are doing non-intervention. This is like a real world. You are just trying to get the investigation. Huh?
Shouldn't we, I mean, this is something you could even consider an ICMR grant for the screening part of it, because who is going to pay for the cortisol tests and everything? I mean, I'm just suggesting, because then it'll be nice to, yes, be all centralized.
You are not doing anything, just getting it test. We can get.
But let's do it as a
I think the doctors who are screening can pay. The cortisol is just 300 rupees. Even if you screen
it's
20
future use
patients.
of the data. If you have done the ethics committee approval, done the consent form that this data will be used to develop, you have a lot of value to it going forward. And therefore, applying for a grant becomes so valuable rather than saying, for example, when I was doing my endocrine fellowship, the criteria was 5 microgram per deciliter. During my fellowship, it went down to 3.
That's because the clear test.
Diabetes India is
because
going to
of clear
support
test.
this study. Bansi is agreeing to it that Diabetes India is going to support this.
Cost, if suppose at all required, we can always, but simultaneously, your idea is very right. Because it requires more investigation. ICMR, to write a grant to ICMR is a great idea. But to start with, let us do it. Maybe, see, out of 50, only 10 may do. May not agree everyone, will not do even if you ask them. So we will write 100 centers in India. Out of them, 20 may do. With the 20, whatever they will do, we will send them some small amount of money if they have.
The idea is the catalyst.
So once we have some data, it is good enough for writing for a bigger grant also. So we write for the grants, but we start off with whatever support we are getting from Diabetes India. We'll start the study, and then we write for bigger grants when and all the data that we're going to collect is not going to be just for the cortisol. You're looking at the profile of uncontrolled diabetics. You're getting so much information on that, and that also can bring out a lot of
Blueprint.
information.
It'll be a fantastic blueprint
So-
because the Catalyst trial is sponsored by Corcept Therapeutics. That is why there is so much antagonism to it also.
Yeah.
It is sponsored by the company that makes mifepristone. So
Yes.
therefore, applying for a government or some other grant has value.
Problem in India, even if it is, tomorrow, because this drug is already off patent in India, but it will never come in India because it is also used for pregnancy termination. So the government will never allow this medication to be used by anyone. It can be misused and abused. It can be used for pregnancy termination. That's the problem.
And Diabetes India is never going to manufacture this molecule. So then, so we are just going to do meetings, but we are not going to manufacture any medication. So we have no conflict of interest on that.
And 23% had a positive CT scan, and those can be surgically treated. So 23% is also a big number. So yeah.
And Mayur will define it has to be in an NABL lab, so that the quality is
CLIA
nationalized.
based lab. All those things would be defined. It should be a clear test only, no immunofluorescence.
Yeah, that will require a lot of discussion to come to that.
That we can keep on
We can
discussing.
do it online. We can do online discussions on to
Yes.
come to a conclusion. Yeah, but just take
We
the
can take the picture also.
signature
so
and all that.
Yes. So we.
That is the consensus that we have.
Yeah, before we end, we can come for a group photo and we can end this session. This side, sir.
आ जाओ 5 साल ये लेके आ जाओ भी कुर्सी